I'd like to call the health meeting to order. Councilor Taylor, would you give an invocation, please?
Absolutely. Heavenly Father, we thank you for this opportunity together today to do the work of the Cherokee people. We pray that you keep us forever mindful of the decisions we make and how they affect our constituents. Pray that you'll be with our servicemen and women, both here and abroad, who are standing in the gap for our safety, and be with our own Cherokee veterans who are traveling at the time. Keep them out of harm's way. For it's in your name we pray. Amen. Amen.
Shelley, roll call, please.
Sir, Frankie Hargis, Brian Warner,
Aye.
Bill England,
Honey.
Keith Austin,
Here.
Jack Baker,
Here.
Harley Bezzard, Joe Bird,
Honey.
Sean Crittenden,
Honey.
Don Garvin,
Honey.
Wanda Hatfield,
Honey.
Rex Jordan,
Here.
Eric Lay,
Here.
Curtis Snell,
Here.
Denise Taylor,
Here.
David Thornton,
Honey.
Victoria Vesquez,
Honey.
David Walkenstick. We do have a quorum.
Thank you. At this time, I would entertain a motion to approve the minutes.
Make a motion to be approved.
Second.
And a second. Okay, let's look down and we'll go with reports. Looks like we've got Miss Kathy Smith from Claremore.
We didn't vote.
Sorry about that. All in favor?
Aye.
Thank you. Thank you, Jack. Yeah. Jack will let you get away with it.
Well, good afternoon. I'm standing in for George again, which I don't mind a bit. The weather outside's wonderful. Drive down here was fabulous. So, anyway, things were still plugging along at Claremore. Everything seems to be going pretty good. We finally have a recruit, the chief of dental services. He's coming on board. He already works for us as a contractor, but he'll be officially in his position in November. He's closing out his private practice. So, October, we're going to start kicking off our flu campaign. It's that time of year again, so we've started having some meetings about that. And tomorrow we'll have our mammography FDA inspection, so hopefully that shouldn't, I don't foresee any problems with that. So anyway, that's all that I have, I think.
Entertain any questions? Councilor Austin?
I noticed under your orthopedic still says out being negotiated.
Yes.
I know in my world, if something took a year in order to negotiate, I'd go broke waiting. So
Yes, no
a lot of
kidding.
people are
Yes.
a lot of people are bringing inconvenience.
Mhm,
Is there any
absolutely.
way in order to get this thing to where it's off of High Center?
Actually, George told me before I came down here that they are meeting Friday with area office people, work out a few more small negotiations, and they hope to have that started by October 1st. So,
Started?
the award for the proposal to be awarded to the orthopedic service.
Would it be possible for when that happens to notify us?
Absolutely, absolutely. Yep, you bet. I know that's been a long time coming, so, and it's terrible to make our patients drive to Oklahoma City. So, yep, I'll be glad when that's done.
Anyone else? Thank you. Good
Thank you.
report. Brings us down to Ms. Connie Davis, Cherokee Nation Health Services.
Good afternoon.
Hi.
We have some great news to report. This is, I don't know if you've noticed in the press or any of the announcements, and you've heard us talk and plan on our public health accreditation. We were notified about a week and a half ago that we have accomplished that recognition. So kudos to Lisa Pivick and her staff. We are the first tribe in the United States to accomplish that recognition. So this is a big deal for Cherokee Nation, another history-making moment in the health system. And there's an article in your handout that details some of that information. We've been busy in our clinics as usual, and just going through the report, you'll see the number of visits are increasing steadily for all of our health clinics. We're back on track, seeing the same number of patients or very close to as we were new electronic health record. So kudos to the staff. We are a year into that process. Let's see. Wanted to direct your attention to our revenue, and something is kind of out of order what I wanted to show you. But toward the back of the packet, I believe it was in mine, is a report of the monthly cash collections, which is our big concern, is how we're doing on our cash. The revenue trends are going the direction we want, but getting the money in the bank has been our big challenge. So I'll give you a minute to find this document. It looks like this. And it reports through July, and just yesterday morning we received, or maybe it was this morning, I'm sorry, August, our cash was $12 million for that month, which is a record in collections. So our trends are definitely going the right direction in that department, and that gives us a lot of, alleviates a lot of stress from us.
It's page 23 of your reports.
I'm sorry?
Page
23.
of
Oh,
our reports.
thank you, Shelley. Hypertension and type 2 diabetes continue to be the major things that we're treating our patients for in the month of July. I think I mentioned last month that several of our staff were recognized at the Area Directors Award in July, and a lot of the quality management staff received recognition for the Peer Award and Outstanding Service, and those names are listed in the packet as well, so kudos to them. We also had several commissioned officers promoted. Would like to mention Dr. Greg Woody. He was promoted to captain. He's delivered a significant number of babies in our health system and has served many years to Hastings, and he's also went to Claremore on several occasions on his own to help with their shortage in OB directors, or providers. We feel like that was very well deserved. Carrie Barrett from the pharmacy, Jamie Tapp also from pharmacy, Dana Cash is an ER nurse, and Dr. Burkhart, who is our audiologist, received a promotion, so kudos to them as well. Dental services, we saw 6,892 patients, 1,030 of those were emergencies. Also happy to report that Contract Health processed over 6,000 referrals, and 97% of those were approved. So we're still doing a good job in that. Behavioral health services saw 1,978 patient visits. There's a handout on the Zika virus included in your packet, but there were a lot of questions for follow-up during last health committee, and if it's all right with the chair, I would like to get Dr. Steve Jones to answer some questions on the dental clinic, and then changing hours of operation, and then a follow-up to Council Lady Vasquez request for a letter to go out to patients. We have a lot of documents to share with you as a follow-up to last month, if that's permissible.
Councilor Crittenden, you had a question?
Yes, ma'am. Connie, thank you for coming by this morning. Answered a lot of my questions. Council, there was a constituent that had brought me this Saturday. It's on your, it should be right there in front of you. It was, she come to me, felt like she wanted all of us to see the situation, and I said, we can do that. And sounds like Mr. Hale and Ms. Davis, you're going to have a meeting with this lady to answer her questions, so thank you for that. Also, it sounds like when we visited there, just wanted to share with the council, and I was adamant to explain that I know and expect that our health facility staff's doing wonderful. So don't say that I said they're not. But I think in every job, I teach school, sometimes it don't hurt a thing. I feel like I'm doing it, but superintendent comes by, says, Mr. Crittenden, let's make sure that these parents, grandparents, and students know that that our primary goal is to serve them, treat them with courtesy. And so I would like, Connie, Ms. Davis and I talked, just a reminder, every so often, hey, we work for these people, and I know you know that, and I know they do, and they're doing a good job. But I don't think a reminder, hey, these people, all the time, even if they're in a bad mood, they need courtesy. So I hope
Completely
that's
agree.
taken well, how I presented that.
Oh, absolutely,
But,
absolutely.
And been assured that the Stillwell Clinic went through some changes, but there's backup coming.
Absolutely.
Thank you. Thank you.
Sir.
Thank you. All right, Connie, do you want to, Counselor Taylor?
I had a question from your report, and it may be on page 13, that's the number that I've got, and it's where you're talking about what's going on in the different things. This is under Hastings Hospital, and it is the collaboration with the University of Oklahoma's Center for Creation of Economic Wealth. I'm not clear on what initiative that is that we're going for. Can you expound on that?
Well, they have a group of young individuals who are very innovative, and this is an effort to put innovation into addressing some of our challenges in health. And so we're working with them, and they do this outside of the box thinking, if you will. They have expertise come in, and they may help us analyze our processes and look at ways to improve things in a way that maybe hasn't been tried before. They work with other companies to introduce new ideas and delivery of patient care. It's a big, there's a lot of what ifs, I guess, that could be done with this.
Okay, so is this an ongoing grant? Is this a one-off situation? What,
This is a partnership. We don't have a grant with it.
We've applied for a grant.
it says a grant proposal submitted.
We haven't received the grant, but hope to. I don't know if I've done it justice, Brian.
This Center for the Creation of Economic Wealth is a program that CNB helped us kind of collaborate with. They gave us some recommendations for basically generating innovation within health services to take care of some of our kind of unique challenges. Their ultimate recommendation was the development of an innovation center for Cherokee Nation Health Services, and they came up with some strategies for implementing it. We've applied for a grant. We did not get that grant. We're going to continue applying for some others and look for a way to source this. This is a way for us to be part of these innovation incubators that provide not really new products, but maybe new processes, software development, things like that for health services.
Okay, so are we providing employees? Are they recommending that we staff this? Where's the manpower coming from? What,
Right now, the two contacts are me and Brian.
I'm sorry, Brian?
Currently, we have no staff dedicated to this. We don't have the resources for it, so we were trying to find resources for it. That's why we applied for the grant.
Okay.
Counselor Lay?
Thank you, Mr. Chairman. On the contract for the cash collections over there on page 20, council kind of started really digging into where these numbers were a couple of months ago, and all of a sudden in May, June, and July, we're looking pretty good. Does that mean we just keep asking you guys and you get better with it, or what?
No.
I don't understand exactly what happened.
There were some software glitches, if you will, and a correction was put in place in May that allowed us to collect, I believe it was Medicaid visits we were lacking, and we still continue to miss some. And that, what was the name of that? There was a term they used that wouldn't mean any more to you than it does to me in ways, but it did have a serious impact. And I think it also helped us catch some ER visits that we were missing at the time.
Is Cerner now on its own, or are you still running side by side with some aspects of RPMS?
RPMS, the only thing we're using out of it is contract health referrals.
So do you check one against the, I guess, explain to me, do you check one against the other? or use them both at the same
They-
time for,
We do. I mean, if they're looking for insurance information or some information that may be missing in the current record, or they feel like may be in the old record, they will access the old one.
thank you.
Councilor Thornton.
Ms. Davis, I've had a couple of calls here in the last couple of weeks, and they're primarily from elders with diabetes, and they want to know why their eyeglasses they can't get transparency in their eyeglasses. And they say that they're told that they're out of money, that motor fuels tax run out.
Well, that is inaccurate information, because that is not the case. So if you can get me those persons' names after this meeting, we'll follow up on that.
Well, I checked down there, and they said they turned down about 5 or 6 people for that.
That should not be happening.
Okay.
So we need to look into that.
Any more? Councilor Lake.
Just to follow up to Councilor Thornton, so I'm not hearing about motor fuels tax, but I am hearing that we're delaying some folks until October 1 when because we're out of money, is what they're being told, for certain contract referrals, out referrals. So we got plenty of money, or we don't, or which is it?
We continue, obviously, to provide the same level of care we've always provided. I believe,
I understand your percentage, but you don't, maybe you do understand. In the Claremore jurisdiction, we have outpatient, which we kind of sort of fixed. The inpatient, we're still running on the old system. So some of my people still have to go through that system to get, before they even get to the board in Tahlequah. And so they're being told they're on hold, because it would be an inpatient procedure. So, here again, do you have plenty of money, or don't you, or what?
we are doing well with our current funding, and I'm just having to guess at what some of these issues may be, sir.
Well, and we can't talk about
Right,
it. but-
and there are cases sometimes, like for knee replacements, those kinds of things. If a patient is getting close to getting Medicaid benefits or Medicare benefits, we may ask them to wait an extra 2 months, because there's such a significant savings to our contract health dollars if they can just wait another couple of months.
Okay.
And so I don't know if it may be one of those things.
Well, and I think it may be, but
Okay.
I want to impress upon, while the chief's sitting here, that we're still not equal in the Claremore jurisdiction to what's going.
I've seen a lot of those letters that say because lack of funding. But every one of those letters is IHS. They're the ones that do the first denial, and they say due to lack of funding. Ours don't say that. Is that correct?
We
Well-
usually, Brett's here, he's the expert, ours tend to be denials on services available, one of our facilities and locations, or it's a service that is not normally approved, elective type service, or
Need more medical documentation
need
from the
more medical
provider.
documentation.
But I get the same complaints. You're out of money, you're out of money. But when I track them down, it's a letter from Oklahoma City saying that due to lack of funding, you've been denied. That's when it kicks over to Brett's folks for them to look at, to use the 5%. But have you ever sent them a letter that says, we don't have money, or we're out of funds?
I think the letter we have, you could interpret it, people obviously interpret it that way, but it doesn't say due to the lack of funds. It says we can't approve this right now, we need more medical information,
Yeah.
it's out of the scope of service or
Yeah.
certain things. It's just a different way to say it.
And that-
But it is, we can't approve an ER call-in until we review the medical information, so that's kind of what goes into that pending mode.
And that's one of the the other letters that Mr. Hayes is going to share with you guys that we've drafted, so we can get something in a patient's hands. If we know for sure, we'll be able to cover that visit or something of that sort, that they've got some sort of documentation just to share with those vendors, if you will.
I don't think this has been resolved yet, but I'm going to continue to speak up for my people, because I think that we're still going through an extra step, and Chief and I has talked about this before, and I understand the IHS letter, but I also understand when our patients are told by doctors at the clinics that we've got to hold off on that until October, November, whenever this other contract referral funding comes in, and that we can't send you over now. They've already been through and denied it IHS. We know that's almost automatic. And then they're sitting there waiting on the other. And I didn't get much cooperation with one patient I'm thinking of right now to try to get an MRI at Tahlequah City, when it's my understanding we own half of that MRI.
You're right, sir.
So they had to wait several months to go through Claremore. And, you know, I hate to just keep dredging this stuff back up, but it's easy to sit there and say we get 97%. And you may be right on the things that go through your board at Tahlequah. But I don't think that's quite correct on what actually I'm seeing coming out of the Claremore jurisdiction, especially for inpatient. We did a lot of work on outpatient, and I appreciate it. But we're still not quite there. And I want to impress upon, you know, here's the thing, we're going to build a 500,000 square foot facility in Tahlequah, and I voted for it, and I want it to be there. But I also say, let's equalize these things out. That's my point, and that's all I'm saying. But I'm going to continue to say that until it's equal. Somebody, you know, you guys are the smart guys, figure it out. That's all I'm asking.
Understood.
Thank you.
Yes. Couple of things. On the budget, when during your staff meetings, you probably need to let your employees know how this funding system works. 'Cause I hear those same things. I'm not sure they're able to distinguish between the funding of one agency to another. And they need to know what they're talking about before they give an answer to our patients.
I agree.
You need to discuss that during your staff meetings. And I'm not trying to tell you guys what to do, but when I hear things like that, usually they don't have all of the information. They're just guessing. But second, there's the visits that I'm looking at that we have here at our recreation center, 8,400. If you can get with Lisa and maybe give an incentive to some of those people that have over 1,000 visits. One of them's like an 83-year-old lady that leads the way. And then there's a 500 club. There's about 127 of those. Those are the people, if you keep that incentive going them, they'll stay out of Hastings, they'll stay out of Claremore, they'll stay out of your clinics. So I'm talking about preventive medicine here.
I understand.
We really got to stay on top of that. That saves dollars. When I look at 8,000 visits, then you go to Wilma P. Mankiller and you have 10,000 visits, we're almost equivalent to the visits you have in these clinics.
Right.
So we need to do a better job of using this preventive health and letting our people know that. Lisa does a great job.
Yes, she does.
Now, give that 83-year-old lady some type of incentive. And you mentioned type 2 diabetes. We had a lady there that lost 65 pounds. She was type 2. She doesn't take any medication anymore. She's not diabetic anymore.
That's awesome.
Those kind of stories need to be told.
Yes, I agree.
About, okay? I appreciate everything you guys are doing. Thank you.
Thank you.
Thank you, Mr. Chairman.
Okay.
Okay. Brett, do you want to come talk about?
There is some incentive on those shirts. So I got one of those 500 visit shirts.
Really?
I think their counting's off though, because I don't.
Okay. You want to give it back?
I don't have it yet. I haven't been over there to pick it up yet.
Okay.
That goes one way, this goes another.
Thank you, Brett. That's good. I didn't know we were going to do that.
Yeah, there were. That's what I heard.
Good news already.
Okay.
Thank you.
A couple months ago, we talked about a packet. We're trying to just close up a few loose ends we've had with you guys. The first, about 8 pages, it's a packet we send to all of our vendors. And we've been doing this off and on for a couple years, but this one was updated in 2015. And it's got no sensitive patient data. It's got, if you'll notice on the back page, I was worried because it had, the back page, the last one of it, it was, the patient's last name is Jingleheimer Schmidt, so. But it's a way to tell our vendors, here's how we want you to bill us. Because we are Connie mentioned RPMS. We're kind of the last true RPMS place that these vendors deal with, and we're going to be there, but we're not there yet. So our goal is when we get a claim in the building, and it's what we call a clean claim, it means it has a PO, the HICFA, or the 1500 from the vendor, and if necessary, an EOB from the insurance company. That's easy. That's so easy to pay that I think I could pay it. When it comes in with just the claim, it goes into what we call an orphan claim. It doesn't have all the, and we get about 70% of our claims in orphan status, and they go into a pile. I mean, we work the clean ones first because they're getting them to us. So we're trying to get this. We're trying to get as much of our business as in clean claim form. So often when you find a vendor that's having trouble getting money from us, it's because their business is coming in and it's not meeting this, and it gets put into the batch to work when we catch up. So that happens, and it's just there for your information. That's the first, really all but the last 2 pages. And the next to last page, you may want to ask questions about that. They can, or obviously it's your meeting, or you can email me or call me, however you want to do that. The letter attached is the next to last page, and that is, it's kind of our draft letter. If a patient is getting bills that they keep getting, that we can send to that vendor and say, hey, get us this information so we can either pay it or tell you why we're not, maybe it's an echo read for a date that we didn't have a referral for or something like that. So that often a patient will have a bill they didn't get referral or something like that, and that happens. So that's just our draft letter of that. And the last one, Mr. Lay had asked, and more than a few of you had wanted information on denials per clinic, and that's just a breakdown of 2016 data. And I did get concerned when I saw some zeros on denials, so I actually physically drilled down into 2 months' worth through the PDFs, and I validated that. So because outpatient a lot of our denials are inpatient. They're for things that are bigger. Somebody had a car wreck, that's going to go pending. To check the medical records, things like that. So that's just the data that had been discussed. And the one thing, Mr. Lay, I was thinking about when you were talking about the October 1st type things, we do want our patients to be screened for ACA if they're eligible. We find them all the time that it costs them $10 a month or zero, or they get a zero plan. And that's a really, once they can get that, they don't cost us anything anymore, and they're able to get services that we might not even be able to provide. So we want them to get screened for ACA stuff. So that could be part of it. And that's a really gratifying moment. I've kind of walked through when they line a mom up that needs some kind of medication for their kid that they're not getting in the hospital. I think the one that was at Claremore, it was ADD medicine that we didn't provide, and she was visibly, choked up. It didn't cost us anything, didn't cost her anything. So jumping through a few hoops on screening is really good for things. So, contrary health question.
Any questions for Brett?
No, this is a good chart, Brett. I mean,
It is.
for the numbers that we have there at Hastings, 22,000, 27, stand denials? I mean, and you go through usually most everyone gets denied the first go around.
Well, no, a lot of these, the call-ins, they went to the ER, and sometimes if the doctors determine that you could have come to Hastings and you went to, somewhere else, that may get denied.
Sequoia County looks a little high.
Sequoia, we get a lot of more, I think a lot of our call-in data comes from Sequoia County. It's more difficult to get from Sallisaw to here than it is from Muskogee to here. So that's.
We want to be like Benita and Claremore.
Yeah.
I mean, Cherokee County.
I think we need to put a four lane in between here and
Yeah.
we can save money that way.
Is that an indicator of how many people you think go across the river services?
Directly is.
Okay. Yeah, I've seen that.
Well, you and I, we have a lot of business.
We've discussed this a lot.
Yeah.
Yes. And I've had suggestions on how we can do that. And I know that you guys have been working with us really hard. I'm very appreciative, and the hospital and everybody else is very appreciative. I'd love to see more conversation about some of those things that we talked about.
Yeah,
too.
I think half of our ER call-ins come from that.
I think so. I definitely think so.
Yeah.
So,
Good job.
Councilor Critton?
Brett, does I know you can't pinpoint it, but like you said, could have made it to Hastings. We had an issue last week and it got, but I mean, how do you?
It's that's a medical judgment. Our doctors are reviewing those. So.
Do they know where all these little places are that people live, like Vail and, and.
Well, sometimes I'll get an email, where is this place? Because we have, Muskogee County's we have the ER from Muskogee County. So sometimes that's an odd, next thing you know, we got a place where it has to be.
Right, and I know that don't just point right at you, but like the issue we dealt with the other day, I mean, it was denied 2 times and finally.
Not 2 times. I think the first time it didn't have all the records, and the next time
it was just clear as day to me. I mean, if you're taking blood thinners and you need 14 stitches, I mean, could you make it to Tahlequah? Maybe. It's, you know what I mean? Right. But I'm glad we got that resolved. But I was just curious about if that happens a lot, because it seemed kind of relative to me.
It happens. It happens frequently, and we find a lot of patients put down in there. Well, I'm not going to say that. So, I mean, patients aren't the greatest provider of details sometimes, and when you get into the medical records and things like that. So, I don't know if that's.
No, that's pretty simple there. Thank you.
Councilor Walker-Stick?
This question is for Dr. Jones. The dental assistants have been contacting us about a change of hours. Can you kind of brief us on the purpose of that? And kind of was it more effective, or because evidently
Let me get with Councilor Lay, and then Dr. Jones is going to come up after Brett.
Oh, is he? Okay.
Yes.
All right, sounds good.
Councilor Lay.
Oh, go ahead, a little bit.
Thank you, Mr. Chairman. You and Dr. Montgomery came to Jane Phillips several months ago.
Yes.
What has come of that?
I believe it's in contract, but we use them. I think we're going to reach out to Dr. Little to make sure they have a good rapport up there, which I think they already do. So I think and I spoke with St. John's this morning before I came here on some other things.
And so is there a necessary contract with them, or just?
It's not necessary.
I'll shake your hand and we'll do business?
Oh, that's how we have, with a hospital, they have to extend us Medicare rate with all the hospitals. So it's not a necessity to have a contract, because they're happy to get it, and we're happy to send people to them. And we want to keep people closer to home. So we got that ball rolling already. We'll follow.
When folks when there's an emergency run from an ambulance, they will not take you to Claremore, they will not take you to Hastings. By law or something, they have to take you to the nearest facility that can care for you.
I think it sometimes depends on, I'm getting into matters, it sometimes depends on their backup availability, because you'll get they'll drive somebody to Hastings, but if they don't have somebody else that's maybe, another truck that's maybe available. So it varies.
And it depends on the chief complaint of the patient and the assessment of the medics on that run. They have to make the determination.
When we're barely providing ambulance service in some of these small communities, there's one. Okay. So they're gonna take them to Bartlesville or Nowata or Bonita. And Bonita's had got a big clinic, but they don't have it, we don't have a hospital in Bonita. So that's where some of my problems are. As you know, then if they didn't call in time to Claremore, if they didn't call in time to the clinic that takes it and runs with it, these contract referral folks, they can take it and run with it and do sometimes, and make sure everybody gets contacted. And that's when there's a lot of breakdown. And, you know, you get calls from me and other folks from up north saying, okay, Claremore denied me because I didn't call them in time. But I did call them, but, you know, they can't prove it.
Yeah.
I guess if they emailed them, they could prove it, but they can't prove a phone call. And then, so when that happens, then it's sent through the clinics to you guys. What happens then?
Then it's reviewed for 5%, you know, but basically we've given, whether it's approved or Claremore gets the first look at it, or Creek Nation, because we have some with Creek Nation as well. And then once they've said yes or no, we utilize that appeal to the next level with us.
Do they generally say no? Claremore and Creek Nation?
Often, I don't want to say
Often,
generally,
yeah.
but some.
Often's a good
Let's just
word.
say some.
And so when that happens, then do we take that expense on, or?
If it meets our medical necessity, yes. And that's kind of our code word, not code word, but if it's not something we would, you know, if it's something you could have gone to Hastings for and they went somewhere else, then
Yeah,
no.
but you can't get to Hastings from
Right.
Copan, Oklahoma. Trust me, you can't.
Or
get
not
there.
Hastings, well, I mean Claremore or something else.
Well, you can't, they won't even take you to Claremore.
Now, when the ambulance is involved, that kind of changes the
Yeah.
tenor of it, so.
So that's part of my problem. So
I understand.
help me figure that one out.
You mean now?
No, not now.
I'm not here all that.
Now, you're not gonna be able to turn the gears that fast now.
That's a challenge. I mean, it really is a challenge.
I know, but that's part of my problem.
I know.
Okay.
That's why I keep talking.
I'm gonna throw one more thing at you guys. I keep looking at the 26.8% in Southstar. Can we not implement a similar situation as we do here in Cherokee County with Sequoia Memorial Hospital to utilize emergency room and some type of a MOU agreement there?
We actually are in discussion with them with some ideas on how we can make something like that work.
Yeah, because if we don't, we're gonna keep losing good medical people down there with this type of percentage denials there.
We've got a couple of ideas that we think will really help access.
Would you please keep me updated on that?
We sure will.
Okay, thank you, Mr. Chairman.
Everybody finished with Brett? Dr. Jones?
Thanks, Brett.
Save the best for last. I tell Connie all the time, the dental program is the best
All
program.
the time.
So, all right, so I know there's been some controversy and some of you have been contacted on behalf of some of our staff about our change in hours of operation. So what I'm going to tell you first is what we're doing, and then I'll kind of go over the why, and at the end, if you have some questions, I'd be glad to answer those. And what we're basically doing is changing our operational hours from 7 to 5:30 to 8 to 5. Now that is when we're actually going to be seeing patients, between those 8 to 5 hours. And there's several reasons for that. And I'll just kind of go through those and give you a little insight to why this came about. The first reason is patient safety. We had an issue in the past. The only clinic that has emergency services before 8 o'clock is the Hastings Hospital. So we had an agreement with the medical director and myself. We worked out an agreement that we would not see any emergency patients between 7 and 8. Now we will sign them up and we will triage them and we will continue to do that. But we don't see emergency patients between 7 and 8. They have to be patients of record. They have to be ASA 1 or 2, which means relatively healthy patients. They can't be medically compromised. So it creates a very narrow gap of what patients fit those appointments, because we don't normally have emergency services on site. Now, that's one of the first things that we looked at. We did have a couple of issues in the clinics where the medical directors were not in favor of us seeing patients at all. So with Dr. Montgomery and I, like I said, negotiated this out and came up with some compromises that allowed us to do that. And when we look at the last 6 months of patients that we see between that 7 and 8 o'clock hour, we have a high rate of no-shows or broken appointments, or non-field appointments, where they don't even find a patient that fits that criteria to put in that position. So I know it's a little bit of a change, but that's one of the reasons that we've made those changes. So I'm going to kind of go through my notes here. The second issue is staffing changes. When we're trying to fill those hours from 7 to 5:30, it creates a shortage of staffing on Mondays and Fridays. And I'm going to give you a little background of what we've done with our providers. All of our providers are on an objective evaluation schedule, which means that they are basically evaluated every 6 months on their production per patient, their number of patient visits, and several factors that we look at every 6 months on our providers. And we rate our providers based on that. And that's how their evaluations are done for their merit awards. Okay? We implemented that about 2 years ago in the dental program. So our providers are very in tune with how their productive numbers are, how efficient they are. So when we have short staffing, then I get calls from my providers that I don't have the same ability to see patients that my colleague does because he has full staff and I don't. And that issue occurs whenever we have somebody on FMLA, somebody on annual leave, somebody on sick leave, and in one of our clinics, which still will, where you're probably going to get some more calls because we've implemented an HR, we're enforcing the policy for unscheduled leave over there now. It is a huge problem in Stillwell Clinic that we have a ton of unscheduled leave. So we have a short staff anyway on Monday and Friday, and then we get staff call in and take sick leave, so which they're entitled to. And if they have a legitimate reason to take sick leave, by all means, we're okay with that. But if they're using sick leave just because they don't want to come in, then that's another issue. So we're going to start, or we have started, recommending that they present with a doctor's note when they do that, because it creates a burden on the rest of the system. And then we end up calling around trying to get steal assistance from other clinics to come and fill those hours, because we don't have part-time help. And if you did have part-time help, you're not going to find somebody that wants to work Monday and Friday, because that's your short days, because everybody either wants Monday off or Friday off. So this schedule will also alleviate that. It'll give us full staffing Monday through Friday. Okay. The other thing we're implementing is a confirmation policy, because we're trying to reduce our amounts of no-shows, of broken appointments and canceled appointments. Well, whenever we started implementing that, the one complaint I kept getting back was, we don't have time to do it. We don't have time to do it. So this will allow us to have full staff Monday through Friday and have time to do it. Because we'll have people there that aren't necessarily with a doc that can do those things. So that's another avenue why we're doing this. The other thing that we're looking at is our revenue cycle. And I know many of you have been here long enough, that have been here as long as I have seen our increase in revenue. When I came in, the recorded amount of revenue in the dental program was $250,000 for the year. This year, we're going to hit $5.4 million in our dental program. So we have generated and we fixed our revenue cycle, and we've got to maintain that. Well, as you know, with insurances, there's always things changing. And one of the things that's changing in the dental world it's getting harder and harder is they're starting to implement predetermination, which is what you guys already see in the medical world. So if you have a procedure, you got to get it predetermined or pre-authorized before you have it done. In the dental world, they're starting to do that on the more complex procedures. They've always done it with crowns, but they're starting to do that with more procedures. So I've got to give my providers time to be able to fill out the narratives, communicate with the insurance companies, get those pre-authorizations done so we can maintain our revenue cycle. And the only way I can do that is to give those providers some time where they're not seeing patients. And that time's going to be 7 to 8 in the morning. Frankly, that's the time that they'll do that. There's some other things that they're going to do in the mornings when they come in. They have time to follow up on complex procedures that they've done on patients. That's a customer service thing we're asking them to do. They'll have time to follow up on pathology reports, call patients directly and talk to them. They'll have time to do their notes accurately. We're going to require them to do 95% accuracy on their documentation. We also do our own referrals, so it's going to give them time to do the referral program. They have to write those. They have to sign off on them. They have to get permission from their director at each clinic to be able to send the patient out. And that's our bottleneck to ensure that we're not overspending our money. So that's another advantage to changing this time frame. Let's see what else. So when I look at all those things, and then I look, and I'm a type of manager that looks, and I'm more progressive or proactive rather than reactive. Okay, so I look down the road and I look at what we've accomplished and where we're at. And we have a flat budget. You guys know that because you guys approved the budget. We have a flat budget. We also have a explosive growth in the dental program. We're seeing 33,000 more visits per year now than we were 3 years ago. 33,000 more visits per year. We also have increases in cost. Every year in January, we don't know till January, but every year in January our GSA contracts go up, our dental supply companies go up, and it's usually somewhere between 3% and 7%. We won't know that till January. So I also have expanded the scope of care. We offer crowns. We offer a full complement of services as close to private practices as you can get in any public health service. We don't want to lose ground on any of those things. So the things that we've done and put in place is to make sure we don't lose ground, that we're able to maintain the ground that we've accomplished. Okay. Another thing that we did was we created a new career ladder for our dental assistants. We did that last year, a year and a half ago, I guess, and put it in place. So every one of our dental assistants got a raise, and now they get promoted and raised based on the certifications they get that help us be better at what we do. So every one of them has gotten a raise. Every one of our registration people has gotten a raise since we put this in place. So all these things are factors that we have to look at in our budget and make sure that we're solvent, because we have a responsibility to do that. And I have a responsibility to my director, I have a responsibility to Cherokee Nation, and I'm told by my wife that I have a constitutional responsibility to stay within my budget. So those are the things that we are trying to do by making these changes. I'll continue to monitor. I'll continue to look, forward and see if we're falling off. If we are, I'll continue to make changes and make sure that we're able to continue to serve at the same quality that we've done thus far. So that's the reasons we've made the changes. If you have any questions, I'll be glad to answer.
Councilor Critney.
All right, thank you. Can you give me, before the change, a day, how that went as far as patients? I know you mentioned we used to take drop-ins right at 7.
We still take drop-ins at 7. We're still going to continue to do that. We don't see drop-ins till 8 o'clock.
Is that, have we been?
That's what we're supposed to be doing. That's a directive from me and from the medical director. So if they're not doing that, then I need to know and investigate that. So if you have any evidence that we're not doing that, then I need to investigate it.
So
because that's a directive from us.
We're not supposed to do that to this point.
We're supposed to see any emergency patients before 8 o'clock, except at Hastings.
What about the last patient?
Last patients are scheduled at 4. We will see patients up till the closing time. So, and still yet, our docs are going to be there till 5:30. So if, the docs
Can they do anything without an assistant?
They can. They can still know how to operate everything. They can still put a patient in the chair and see them. If a patient walks in and they have trauma or they have some reason to be seen, they can assist each other. We will still be able to take care of that patient.
No patient lost in the evening?
Should not be any patients lost in the evening. We still have our 4 o'clock appointments just like we've always had.
In the mornings, it never was, they never were supposed to see.
Not emergencies, not from 7 to 8.
So I was having a hard time hanging on to all that. I'm usually a pretty slow soaker, but, so all of this time, when our money's been going up through the roof, we've been understaffed.
We've gotten control of our revenue cycle. So there's a lot of things that were broken that we fixed. We've had an explosion of patients. In our world, we only have 24% of our patients have any type of therapy. Only 24%. So 76% of the patients that come to see us for dental services have nothing that we can access through third party.
So when were their dentists going to do the extra paperwork you were talking about?
Between 7 and 8 in the morning, and from 5 to 5:30. That'll be the time that they have set aside to do their charting, to do their documentation, to do any kind of referrals they need to do, because they're going to see patients from 8 to 5.
And even after 5?
They take a 30-minute lunch, so their assistants will alternate lunch, so we stay open through the lunch hour. And if there's 2 docs in the clinic, obviously they won't take the same lunch. So that our clinics are fully open from 8 to 5. Now, if a patient, we're not going to turn anybody away that's in pain if we're there. But if a patient shows up after 5 o'clock and we have somebody there, then obviously we're gonna take a look and see what we can do. If it's something we need to do something right away, or if it's something we need to that can wait till the next day.
So they will be seen regardless of if they're
Absolutely. If there's
in the
docs
middle of
there,
paperwork.
Right. That's their responsibility, and they know that, and they've known that ever since. Even though we've been 7 to 5:30, if we have somebody walk in, I had a doc 2 weeks ago that I stayed with at Hastings, that we had a patient that had a complication, and we were there till 6:30 at night with that patient. So it's just something that it's part of healthcare.
I would put our access to dental services up against any private practice, because if you go to any dentist in town or in your respective communities, there are probably very few that say you can walk in with an emergency and be seen that day. They're probably going to schedule you for the next day or two. And Dr. Jones has put access for emergencies, especially, as a high priority, and I don't get near the complaints. I don't know the last time I received a complaint needing access for a dental emergency. And in the private practice, I will say that most dental clinics are closed on Fridays. They're not even open. And he's tried to keep them staffed on Fridays, but...
Let me ask you this. So, again, I'm sorry. We are understaffed?
Well, when you take the staffing that we have on budget, and you split that out over a 55-week, 5-hour week, because your staffing is all based on a 40-hour week. So when you come down to Mondays and Fridays, and you have these people working split staffs, okay? So half your staff's going to work Monday through Thursday, the other half's going to work Tuesday through Friday, okay? So half your staff is gone on Monday, and half your staff's gone on Friday. So you're at half support staff, if that makes sense. So, and every doc can keep 2 assistants busy easily, and a hygienist can keep 1 assistant busy. And if you've got multiple docs and multiple hygienists working, trying to see patients, and you've only got 3 assistants to spread between them, then you're reducing the efficiency of the doc. The patients are having to wait longer. And if you have a rash of walk-ins, which we usually do on Monday, then it throws everything even further behind. And that's where we get our complaints, when somebody has to sit there for 4 or 5 hours waiting to get in. And so this is going to alleviate that, because we're going to have full staff Monday through Friday.
Yeah. All right. So, this was presented to me, so I'm just not trying to take up time here, But bottom line is, do you think we will see more or less patients, or about the same?
I think we'll stay about the same. We may increase a little bit. The reason for that is we're going to cap out. There's only so many patients that each provider can see a day. There's only so much time in the day to see those patients, and we're going to cap out. And we've got to be accurate on our documentation, because if we're sending paperwork back and forth between our billing department, and the other thing, that's different with us than it is with medical, that you have to understand from a documentation standpoint from dental, we code ourselves. So if I do a procedure, I have to write that procedure out and document it. I also have to code that procedure, okay? We don't have a coding department that takes our documentation, puts it in the codes, sends it to billing to be billed. We code ourselves. So if that is not done correctly at the time of the procedure and it goes to billing, then it screws up the billing cycle. And then it ends up coming back, and then we're chasing it down. That's why we're implementing a 95%. I would like to have 100% accuracy. I want to give a little bit in the beginning, have a 95% accuracy. I go out and do chart reviews. I've been doing chart reviews and finding these little things that we're missing because, and when I talk to them and sit down with them and say, look, you're missing these things, I just had to sign it. Man, I was in a hurry that day and I didn't have time. I had to sign it and go on. Well, that's not a good answer to me because I want it to be.
That's why we've gone from $250,000 in revenue and dental services to $5 million. And so that time has obviously paid off well for the health system.
Right.
And as I also remind Dr. Jones, it's not just for dental, that revenue goes for all of the health system.
Really? Yeah, that's good. That's good, of course. And, you know, my simple brain says, hey, we did that with this schedule that my folks seem to love. You know, and to me, we're doing good. But let me just say this, Doctor. I appreciate what you do. Stillwell boy. Now, I know there'll be two kind of sides to this, and I kind of have to go with my Stillwell folks' side because that's who I work for. You know, at the same time, I appreciate what you're doing. I know you're doing well. For my Stillwell folks, this chair, I would just ask you to reconsider, think about it. Whatever you can do on those folks' consideration. All right?
All right.
Thank you.
That's what I'm saying.
Dr. Jones, I want to echo what Councilman said here. You've done a tremendous job for the Cherokee Nation. You've gone from 250,000 to 5 million. Great. You incorporated a great system with what was going on before. I know you're always trying to find ways to get better. You don't want to stay stagnant. I'm an administrator at Muskogee Public Schools, and when I go in and implement a system without, and you may have communicated with some of your dentists, but some of your people at the lower the totem pole, when you don't communicate with those people and try and get them to buy in, say this is a great program because of what you just explained to us today. You know, this is why this is a great program. Man, it rubs people the wrong way. I've been where you're at. I've been there, and I've learned. And also with the unscheduled sick leave, with a doctor's note. I mean, we're telling our folks that we don't trust you. Like you're not sick, you're lying. So bring us in the doctor's note. I know in the school world, if you miss 5 days consecutively, you got to bring in a doctor's note. But if you miss 1 to 3, 4 days, or whatever, that's on you. It's your time. You've acquired that. That's part of your benefit package of working for us. But and it sounds like an issue. You got people missing just to be missing, and you're trying to crack down on it. But really, I feel like we're going to lose morale in your world based off the complaints that we're hearing. Now, like I said, I mean, you're doing a heck of a job though, bringing in money and stuff. But and my thinking is, and now since you already set the precedence, like the program's already in place. Now you're at a point that it's a pride deal. Either I'm going to win or the employees are going to win. You know what I mean? So it's out there, and us, the council, you know, we're stuck in a tough spot because we support you. We also support these employees. So we're in a catch-22 here.
I think the easy thing for you guys would be back to what Councilman Crittenden
Well,
said.
what I was going to say is we need to find a median. Like, we need to come to Jesus meeting and say, how can we accommodate you? Because if your workers aren't working for you, you're not going to have a $5 million increase. I mean, they're going to quit you and die down. Need to find a median and say, you know, how can we accommodate you in your schedule? What works best?
Okay.
And I can promise you, you're going to clear the air. The morale's going to be better, and it's not going to be a touchy subject when you walk into the clinic. And people's going to be in fear, or whatever. Like, this guy's easy to approach. He's on our team. You know what I'm saying?
Yeah, and I want to address that just a little bit, because when we started looking at this, we started looking at this several months ago. I met with my directors, met with my supervisors, we talked about it, and everyone felt like this is the direction we needed to go. So then I made myself available. When we announced it, I made myself available, went to every clinic. Every clinic set aside time, went and sat down and visited with anybody and everybody that had an issue. Some people had issues that we really needed to work around. Some people just didn't want to lose their day off. As a result, we worked around a lot of issues. We redid schedules. We have accommodated several people. So there is that aspect of it. As far as, you know, buy-in, I have been their biggest advocate. You know, they hadn't had someone to advocate for them and have a career ladder adjustment since 1999. And it took me a year and a half to get that done, but we got it done for them. So I have been their biggest advocate. It's not a lack of communication or going out. It's something that we've talked about, that I've put myself out there. I've even had them contact me through email and then re-met with them. They have the ability to meet with their director and then set up a meeting, and I will come out there. I've been to every clinic and gave every single employee an opportunity to meet with me one-on-one or with their supervisor if they felt more comfortable.
Is there fear? Is there fear there between you and your staff?
Not that I know of. I mean, I had a lot of people meet with me. I mean, I'll be honest with you, a lot of people met with me. I spent a whole week just going from clinic to clinic on the road.
And, you know, a lot of them, you know, some of them said, you know, if you mention this to a council member, it's like you put a gag order on them. Yeah, I heard that, and I don't know, but
that would be in violation of an executive order. There's an executive order that anybody can talk to anybody, and I have made my directors absolutely aware of that.
Again, there's fear there, and then the performance evaluation, they're saying that I guess you made a statement that it can't be any more than 3% or something like that. Is that?
I don't set those percentages.
I made that statement. 3% is all that we've got.
Okay. Well, some of them got 4.9%.
And they come back and changed them.
Yes, they did. Okay.
Nobody's to get over 3% this year.
They may have got that score on their evaluation, but as far as their merit increase, it's 3% as the chief has directed.
What did you say, Connie?
They may have got a score of 4.9 on their evaluation.
That's what I'm referring to.
Okay.
It's evaluation. Okay. That's evaluation I'm referring to. But they said that to not give someone over a 3 or whatever your grading scale is 3%. So.
That's the budget. But we're here for the patients. I think we have to remember that. I
get
understand we're
that.
sensitive to the employee issues, but I think we just have to remember and remind the employees, you know, we got to do what's best for the patients. And his measures have been proven effective. I know you're not getting complaints on dental services.
No.
I know you're not, from the patients.
Yeah, but you go back, you know, you've had an increase of 33,000 patient visits on the system we had prior to. Now we're switching it up.
Something's working.
Yeah, employees are disgruntled, but we had something that was working before. That's what I'm saying. Was it worth? You know, you got to pick and choose your battle. Is it worth? If it's worth the battle, we're gonna increase from 32,000 to even more, and we're gonna increase our third-party revenue from 5 million to 6 or whatever. I understand that. That's a business model, but I guess you're aware of everything, the complaints that's going on and the conversation going on. So, and when there's change, you're always going to have complaints. I mean, Cerner,
absolutely.
Cerner was one of the biggest uprising. People don't cost anymore. It's either working or they gave up. One or two. So.
I think we had the same uprising when he went to the 410s. Nobody wanted to work those longer schedules. So what you said was absolutely correct. If there's change, everybody gets upset. It's the fear of the unknown. It's change.
Yeah. That's all I have. Again, I commend you. I just want to clear the air, be sure that you done all your due diligence of communication with staff and gave them input in the process. But these unscheduled sick leave, you're going to get a lot of flack over that too, just FYI.
Yeah,
Is that an HR policy? That
We'll
we got
comply with the HR policy, implementing any disciplinary action.
And that's the deal. We're just trying to get a handle on it because we do have an issue at one of the clinics that's a little bit worse than anyone else.
I'd like to go ahead and move this a little bit forward. We're on a tight schedule today. Thank you, Councilor Walkingstick. Councilor Thornton? you
Yes.
do.
Of course, the best thing we can do is accommodate our people. And the second best thing is accommodate our physicians and our dentists and our people that work in that area. As far as local dentists in my area, they don't go have, they don't take patients Monday or Friday, and mainly because they don't have that many patients. You people have taken on a heck of a lot, and taken a lot away from them. Matter of fact, we actually have dentists that quit with local business and started working for us.
Absolutely.
So, that kind of explains that part of it. But back to the accommodation part of it for our people is that we got people that go to work, they work all day long. They may go to work at 9 o'clock, 8 or 9 o'clock, and they come in at 7 and don't have to, worry about it. They can take care of their business all day long, and that's accommodating those people. We've got students that go to school and go to college and high school, and they need to come in early, 7 o'clock, and be accommodated. That's what we're there for, and that's what we spend all this money for that I look at. We're the Cherokee Nation. We're not the private business sitting over here taking care of their own business. And we put out a lot of funding, a lot of federal funding, and other types of funding. So, as far as having the patients, y'all have them. And you've been doing a dang good job taking care of them. But when you do change, you've got problems with changes. And we've had problems with a lot of changes in the health department in the past. And we're going to have problems with this because we need to accommodate our people. And I wish that you would think more about that, about our people that work, our people that go to school, even our locals that take care of their kids, and they have to take them to school and pick them up, and then they have to take care of some of them all day long. And, there's different things that we need to accommodate here, but the main thing is accommodating our people. And thank you.
Yeah. Dr. Jones, a few years ago when you came on board, a lot of questions, a lot of equipment that need to be upgraded, and you've done a good job, you and your staff. I don't get that many calls about the lack of services in the dental department. If I did, then I'd bring it up to you. But when I hear about a management style change, I'm not going to get excited about that because we pay you good money to make those management style changes. As administrator here, Walkingstick, and Mr. Critton here, they make changes daily to their students or whoever they're going to teach. If you're just making a management change, we're going to still see that many patients, we're going to increase our revenue. That's your responsibility. Now, keep the morale going. That's also your responsibility. Right now, you're really doing a pretty good job. 33,000 extra patients in the last 3 years. I mean, there's nobody else serving those type of people out there. Like I told Connie last time, just keep us within budget. Okay?
You're definitely doing that.
Good job. Thank you. Thank you, Chair.
Guys, thank you for coming in. Dr. Jones, thank you for being available early to some of those that could be here. I've called Dr. Jones and talked to him on the phone, and if you have further concerns about what you heard today or whatever, I recommend giving the man a call and voicing those. So thank you guys, appreciate you.
Thank you.
Thank you.
Moving down, old business, I see none pending. New business, none pending. Announcements. Meeting tentatively scheduled for Monday, October 17th at 1.
Make a motion to adjourn.
Second.
All in favor?
Aye.
We are adjourned.